Bienvenue à tous donc dans cette conférence de l'Université de la E-santé de Castres-Mazamet, édition 2023. Et ce thème central depuis ce matin, la E-santé en 2023, a-t-elle toujours la forme d'une oasis dans des systèmes de santé qui sont, eux, sous extrême tension et parfois en état quasiment désertique? Ou bien alors, la e-santé n'aura-t-elle représenté qu'un mirage le temps de quelques mois, après avoir vu ses usages exploser durant la pandémie de Covid, puis fortement reculer pour revenir apparemment aux anciennes habitudes. Et pour apporter donc ce soir des éléments de réponse, de réflexion à cette question, nous avons l'honneur et le plaisir d'avoir parmi nous un médecin de formation, mais également homme d'entreprise, puisqu'il a contribué au succès de Babylone. Alors, Babylone, pour ceux qui ne connaissent pas, c'est une licorne européenne assez jeune, puisqu'elle a été fondée à Londres en 2013. Elle propose des solutions de téléconsultation et aussi, vous allez le voir, d'intelligence artificielle prédictive. Babylone a levé 550 millions de dollars en 2019, 6 ans seulement après sa création, 550 millions de dollars. Et elle affichait l'année dernière un chiffre d'affaires supérieur aux milliards de dollars, avec des applications qui sont utilisées par le NHS en Angleterre, mais aussi aux États-Unis, dans plusieurs pays d'Afrique, en Asie. Donc autant dire que notre invité sait de quoi il parle lorsque l'on évoque les solutions de santé digitale. Je laisse donc la place ce soir au Dr Keith Grimes, qui nous a fait le plaisir de faire le voyage de Londres jusqu'à Castres.
Thank you very much. Hello everyone. Thank you very much for the introduction. Thank you for helping with the translation. My name is Keith. I know that's a very hard name to say in French, so you can call me Kit or whatever you like. I'll respond to it all. And I'm here today to talk to you about how digital health didn't do as well as it should have. In particular, how we overpromised and underdelivered when faced with the biggest challenge that we had at the time, which was the pandemic most recently. So, like I said, my name is Keith. I'm a doctor. I'm a general practitioner working within the NHS, or at least having worked in the NHS. And I'm an innovation consultant as well. And I'm an unusual person in that I have been a doctor for 27 years, a GP for 23 years within the National Health Service. And I've worked mostly in urgent care, out of hours and things like that. But I've always loved technology. My earliest memories are of technology. I've always tried to put technology in everything that I've done as a doctor. And I've done that within the National Health Service. And then from 2018 onwards, I did that within Babylon. And I also learned an awful lot about the world of product, which was a mystery word to me as a doctor. But I learned a lot about it working within Babylon as I worked on the symptom checker, health check, monitor, and a number of different products that we brought to market. I've also been involved in leadership, not only within Babylon, and I helped lead 50 doctors around the world building the products that we had in multiple different countries. But I've also worked in commissioning healthcare within the NHS, and then also had the opportunity to teach as well. So I do a lot of different things, but when I boil it down, I founded my company, Curistica, to do one thing: to accelerate the automation of healthcare. And you'll understand why I want to do that in a moment. It's important for me to declare my interests. If you want to, there's a QR code up there, and you can, or wherever you're seeing it, and you can visit my LinkedIn. It'll say all the details there so you know exactly what to believe when I'm speaking. So, we start, first of all, with the problem. This is just the problem with healthcare, and the problem is very, very simple. It comes down to demand and supply. So let's look at the world, the whole world. So in November last year, the global population went over 8 billion for the first time. That's 8 billion human souls on the planet, many of whom need healthcare. It's going to rise to 10 billion later on this century as well. And right now, we are not serving their needs. Now, I've heard today about how we're not serving the needs here in France. I know how we're not serving the needs in the UK. But around the world, 50% of people don't get access to the healthcare that they need. That's over 4 billion people do not get basic healthcare needs. And this is an unacceptable situation. But people need healthcare, and they will look for healthcare. And so where do they go? Well, they go onto Google. David Feinberg, back in 2017, when he was working at Google Health, talked about there being 1 billion search queries per day on Google. 1 billion people not having their healthcare needs met, they go online. And then I also found out about YouTube. We heard a little bit about YouTube earlier on from Vishal. In 2021, there was 110 billion health-related video views in 2021. And in 2022, 9.5 million videos uploaded. So there's a lot of content being provided to these people to make up that gap. But we're really short of doctors and nurses and other healthcare professionals. We're 18 million healthcare professionals short by 2030, according to the World Health Organization. 18 million around the world. So I'm from the UK, and in the UK we've got shortages. I was hearing some of the shortages you have in France earlier on. And the predictions for the UK is that we're going to be more than 570,000 healthcare professionals short by 2036. And that's a scary number. So I'm a general practitioner. And in the UK in general practice, we've had problems with shortages for a while. Right now, we're about 4,200 full-time GPs short. But even that number's falling. By 2036, they predict we're going to be 28,000 general practitioners short in the UK. I mean, these are impossible numbers to deal with. And there's lots of reasons. People are retiring, people are resigning, people are working in digital health, people are burning out. And what this is doing is this is constraining the supply while the expectations are going up. So people's expectations for healthcare are growing in any case. People want to see their data. And demand has increased following the pandemic as well. We're dealing with the backlog of what's happening here as well. So chronic disease management has taken a very big hit. And hospital care is struggling to catch up. And so with headlines like you see down below, the public is saying, why are the doctors hiding? Why are the doctors not seeing us? But the doctors and the nurses and everyone are working very, very hard. In fact, they're working harder than they've ever worked before, and we're not managing to catch up. And there is the problem. So what's the situation in France? Well, I looked to France. I was a GP back in 2000, and so France was a very well-regarded healthcare system. In fact, it was rated the first healthcare system in the world by the WHO back in 2000. Now, whilst I don't know whether that's exactly the same right now, it's certainly in better shape than we are in the United Kingdom. But then as I sort of dug into it a little bit, I didn't quite realize that the problems with the aging medical population is worse over here. So I found out that 50% of doctors in France, and I double and triple checked this, are 55 or older. 50% of your workforce. It doesn't matter that you have more doctors than the UK right now. There's slightly more. You've certainly got more nurses per 1,000 than the UK. But it seems like in the next few years, you're going to be suffering a really big squeeze as well. And the issues of pay and burnout are the same. And then you can see here some images. We've got strikes in the UK. You've got strikes in France, doctors complaining about their pay. Quite rightly so, it's been eroded in the UK a great deal. So again, the problem is still the same. So where were we? Like, let's wind back a bit. Before the pandemic, 2019, where was e-health? Where was digital health in 2019? Well, back in 2019, everything looked quite good. Artificial intelligence, which had been promising a lot for a long time, was beginning to actually show some interesting research evidence. I recall well the Google DeepMind partnership where they looked at artificial intelligence being able to predict the progression of diabetic retinopathy, or macular degeneration, pardon me. And so they were planning how to put this into place. Now, I was working at Babylon as well. We were using telehealth there as well. It was being very well received. I was working on a symptom checker. I'd just come off the back of working on the Topol review of the NHS, which was looking at how we educate and train our healthcare staff to work in the sort of healthcare system of the future. And there was lots of apps, and everything looked really rosy. And in fact, international studies, this one here done on the state of digital health by Salud Health, actually looked at the entire world and said, actually from digital health maturity point of view, things are quite good. The average is 3 out of 5, 4 out of 5 in some countries, particularly Western countries. Leadership in digital health, governance is very strong, but, and this is an important thing that comes back to bite us, they did warn that standards and interoperability were a problem. And they also said that the digital health workforce development was lagging. So things look quite good, but there are some clouds on the horizon. Well, there's some clouds in what's happening, but the biggest cloud of all was the entrance of COVID-19, so I don't need to tell too much detail. Everyone knows the story very well, but in Christmas, in 2019, January 2020, we started hearing about a new respiratory illness arising out of Wuhan in the Hubei province of China. I was fortunate to be working with Chinese doctors at that time in the UK, and so I had a glimpse very early on in January of what was happening on the wards as she was trying to arrange PPE for them, and so had an idea of what was coming down the line. And then we all became aware of it as things started to appear in Italy and then everywhere. And the pandemic was declared on the 11th of March 2020, and then around the world, lockdown started to come in shortly thereafter. And we moved from a very complicated healthcare system to a complex healthcare system. Care switched very much to acute, away from chronic. Supply started to get very strange and constrained. We were in a very, very unusual situation. But digital health. A hero arrives with digital health. And at this point, everything about the pandemic seemed very well set up for digital health to really prove itself. It's almost perfectly designed for digital health. Why do we say this? Well, if you all recall at the start of the pandemic, as we knew very little about this new disease, lots of data started to arrive. And this huge amount of data was overwhelming our ability to cope with it. But wait a second. We have artificial intelligence and informaticians. We can use them to handle the data, no problem. And then, well, we're going to have to lock people at home. That's okay. We've got telehealth. They've got mobile phones. We can care for them at home. That's no problem. Technology looked as though it was going to be able to adapt quickly and scale fast. And moreover, whilst we do not have global coverage of internet connectivity, it's still not in bad shape. 2/3 of the world population have access to the internet currently. Now, we've heard earlier on about some of the challenges in there, but certainly it was looking quite good. So we think, well, we're facing a really difficult time, but it's okay. Digital health says it can help. Time to step up. So my question, or the question that everyone's asking is, like, did digital health rise to the challenge of the pandemic? Well, it's complicated. If we think back, there's a lot of things that we wanted to happen that didn't happen. And what I'm going to do is I'm going to take us through maybe 3 areas. And one thing I don't know is how you do report cards in France. So let's assume when you're at school and then you get a card back to your parents. I don't know if you had it and it says how good or bad you were. So why don't we use that and we'll say, well, how, if we look back, did digital health in these different areas live up to its promise? Okay. So where are we going to start? Okay, well, we'll obviously start with artificial intelligence, because artificial intelligence is brilliant, isn't it? It's going to solve everything. So we'll start there. The promise of artificial intelligence, and going into it, it was that, like I said, it was beginning to look like there may actually be some value in it. I talked about DeepMind and more fields, but also in radiology, we're seeing some research papers. I know there's some radiologists here earlier on in terms of interpreting and assisting with triage in radiology, so maybe that's going to be helpful. Is a respiratory disease after all? We're going to get some chest x-rays, we're going to get some CT scans, that'll be helpful. And of course, I was working on a symptom checker that was helping people understand whether they should seek help and where to seek help. So, you know, that should work quite well. And then the rapidly evolving situation seemed pretty well suited to it because we could use machine learning to forecast infectious disease dynamics and the effect of the interventions we put into place. Or maybe we can detect some outbreaks here and there. Maybe we can surveil the response to it. Or we can monitor adherence to public health measures. You certainly maybe saw facial recognition, compliance with things like masking and social distancing and so on. And even detection of illnesses by detecting subtle biomarkers or digital biomarkers when the tests haven't even been developed yet or are scanty. So artificial intelligence sounded like it was going to be very good, particularly when the interventions are unclear, lots of data's arising, and the public health measures that we're inevitably going to have to put into place, or that were put into place, actually had some significant consequences. And in the early days of the pandemic, it actually panned out this way. There was a huge rush of models. And actually, some of them were quite successful. So I don't want to throw it all away just yet, but actually some of the early work was quite good. There was some value in using machine learning to be able to detect the pattern of illness and outbreaks as it was starting to be available in different areas. So that was proving quite useful in terms of prediction. There was some vaccine trial success as well, where Pfizer used some models to actually clean the summary data that they got in for the vaccine trials, which actually allowed them to accelerate the development of their vaccine. And then when it came to rational testing, in Greece, they used a system that helped them identify which people to use their tests upon. And actually, this was actually quite productive. So there is some signs that it can be used, but it's interesting because it's in the sort of epidemiology and the logistics side of things. And actually, that's where AI seemed to have its greatest impact, was on that side. But people are like, yes, yeah, that's fine, but let's get to the clinical side of things. Let's see the medicine. So how did it perform? Well, I'm going to defer to 3 papers here, and I've used some QR codes, and I can share the links afterwards if people want to see it. But one of the early signs that things aren't quite so good came out in April 2020 from the British Medical Journal. And in this systematic review, they looked at prognostic models for diagnosis and prognosis of COVID-19. Of course, this is very important. We're right at the sharp end of the pandemic at this point. And they looked at 606 different prognostic models. And what did they find? Well, they found that 29 of these models had a low risk of bias. 32, they couldn't tell, it was unclear. And 545 had a high risk of bias. And in fact, they suggested that there's an oversupply of models and external validations that are very high risk of bias, which raises concerns that the predictions could be unreliable when these models are applied in daily practice. So that doesn't sound very good. Well, how about a bit later on? If we look in March 2021, this is the University of Cambridge, and they were actually looking at common pitfalls and recommendations for using machine learning to detect and prognosticate about chest x-rays and CT scans. I mentioned these before. That's a good area, isn't it? Well, that's not right. Because they reviewed 320 papers, of which 258 were excluded owing to quality issues of the methodology. And their conclusion, our review finds that none of the models identified are of potential clinical use due to methodological flaws or underlying bias. So that's not great either. Okay, well, maybe we'll try one more, okay. This third study from June 2021, and what they did here is they looked at artificial intelligence across a bunch of different use cases. They looked at 183 articles in depth. They looked at 1,167 traditional modeling articles where they thought about using machine learning. And in this case, important machine learning-based solutions have been developed in response to the pandemics, particularly for COVID-19, but few were optimized for practical application early in the pandemic. In short, none of these things really worked. And our superhero crashed into the dust. So why? Why did this happen? There's a few reasons. Well, the first of which is a really cool term, I think. It doesn't describe something cool. It's what they called Frankenstein data sets. And of course, earlier on, there was a lot of data, and they wanted to be able to sort of bring this together, and so they cobbled together these enormous public repositories of data for everyone to have a look at. But they were mixed quality from different backgrounds. They were unsuitable for the use to which they were put. And then when these were used, there was examples of overfitting. They would take the data that they would use to train the model, and they would not keep it separate from what they used to test the model afterwards, so the models looked as though they performed well. Why did they perform well? Well, you're just testing it on the thing that you trained it on. Of course it's going to do well. And then they started misidentifying features. Famously, there was a model that was used for identifying COVID in chest x-rays, and it performed very well, until they realized that what it was doing is it was identifying that the people were supine, they were lying. And of course, when a person's having an x-ray and they can't even sit up, they're generally quite sick. So it started to misidentify features as well. And the data sharing was fragmented, and then the staff, the clinical staff and the healthcare staff weren't working with the researchers, and even if they did, they didn't know how to implement it as well. So there was a lot of things that actually led this to perform maybe less well. So what is it that we can do? Well, let's first have a look at this. First of all, we've got data. The data was incomplete. It was of poor quality. It was poorly integrated, and it was biased as well. This is a story that gets told time and time again in healthcare. But for some of the populations who are at most risk of adverse outcomes had the least data provided as well, and so the models were differentially not performing well there. We talked about the implementation issues and the training of staff. But wait, what about large language models? What about ChatGPT? What about Bard? What about Claude? What about all these new large language models? Well, I think the most important thing that we can learn is that we've been caught out before on this. And whilst there's an awful lot of promise with new large language models, we do have to move with care, because we may hopefully not have to deal with a pandemic again for a short while yet, but we still have other challenges, which we'll come back to in a little moment. So artificial intelligence. I'm afraid artificial intelligence, you get a D+. I expected much, much more from you. You did try, but I think you didn't do terribly well. So, let's move on to something else. Telehealth, that's a good one. Telehealth and total triage. What was the promise there? Well, going into the pandemic, video consultations were on the rise. I was working at Babylon, like I said. Now, they'd been offering video consultations for some time at that point, and they'd launched GP at Hand, which was an NHS-based digital-first practice in November 2017, and it was growing pretty quickly. And there were some other providers as well. But when I talk about total triage or digital first, to be clear, this is a situation where you have video consultation or phone consultations and face-to-face. But patients will present first using an online portal to report their symptoms or a symptom checker. And so that was working quite nicely. Within Babylon, we're using quite some nice skill mix, and we thought this is pretty good. And there's some other products out there like Ask My GP and eConsult in the UK. So it was performing well. And then, of course, the pandemic turns up, and I've already mentioned the pandemic is a problem that this seems a very good solution for. You know, everyone was required to isolate. Patients were required to isolate if they were unwell. People at risk were asked to isolate. Staff were asked to isolate or remain away from patients to sort of save them getting unwell. And then if they had to isolate because they'd been exposed, it would allow them to work from home. And the technological base was in fair shape. I mean, people complain. I'm sure they complain in France about the quality of the IT infrastructure, and they complain a lot about it in the National Health Service. But actually, there was a base layer that was allowing this to be implemented. And of course, there's a lot of people using smartphones and technology at home, so this is actually a good thing. People use FaceTime, don't they? They use WhatsApp. This will work. And as a result, video consultations and telehealth grew incredibly quickly. So the availability of video consultations in the UK in November 2019 was 3%. But by June the next year, it was 99%. 99% of practices were offering video consultations. And then the barriers to WhatsApp fell down as well. Now, I'll admit this, as a clinician, I would use WhatsApp to communicate with my colleagues and try my best to sort of minimize the sharing of data as well. And I'd even use WhatsApp to speak to my patients because it was convenient for them and they wanted this. But it was only really made permissible early in the pandemic. On March 2020, we just suddenly got this notice that it was okay to start using it. So everyone started to feel a little bit less guilty about what they were doing. But it just goes to show that when needs must, some things can change. And by summer of that year, both clinicians and the public were actually quite comfortable in using the technology. And at Babylon, we thought, well, this is great. We've already had some successes, so maybe what we should do is we should bring it all together. And we built something called the COVID Care Assistant. And what was this about? Well, we had a symptom checker. So I remember very clearly early in 2020 working late with my colleagues to try and teach the symptom checker how to identify people that might have symptoms of COVID. And more importantly, to take what were very complex guidelines and inform them what to do. And that seemed like a very successful thing to do. In fact, we had quite a lot of traffic for that. But then we thought, well, if we can help them and do that, then maybe we can also answer questions. If the symptom checker can't do this, we'll use like a text-based system to answer questions. And if that doesn't work, we can move them on to speaking to a video consultation. And if that doesn't work, then we can see them face-to-face. And in that way, we can be very, very rational about who we see. And we released this, and we also allow people to track as well. That was the other thing. And on their app, they were able to track their temperature, pulse, symptoms, and so on. This is a great idea, we thought. We'll get this out there. People will love it. And of course, people did use the symptom checker. But even though it was used in a number of trusts, it didn't seem to make that much difference. And I suppose that's the interesting thing. Earlier on today, I was hearing about the sort of regression of telehealth, the regression of where we were before, and that's, of course, happened in the UK. So what were some of the things that kind of underpinned this regression, this step back? Well, the first thing is that the doctors started to get a bit upset about it, at least we found. They felt that they were taking on too much risk. It was okay at the time during the pandemic. When things started to ease up, it was still quite risky, assessing people remotely, and in particular, taking messages from patients using a total triage system. The doctor's surgery might be open from 8 in the morning till 6:30 at night, but the ability to be able to send in requests was 24 hours a day. And doctors started to say, well, I'm coming in the morning, and I've got an enormous amount of work from last night, plus all of the work of the day. So they started to feel overloaded. And then they started to turn off the system overnight so they could manage the demand. Pardon me. And then the patients didn't really like it. There was this weird perception that doctors were hiding, that doctors... And remember, I don't know if this happened in France, but in the UK, people used to come out once a week and clap and bang pots and pans to celebrate the heroes of the NHS. And of course, that turned very, very sour. And the media started saying, well, the doctors need to return to seeing people face to face. Where are the doctors hiding? Why are they not seeing people face to face? But the truth is that doctors and nurses had been seeing patients all along. And they've been dealing with this greater and greater amount of work. And then the government, which had been very much about remote first, take care of people distant, seemed to switch very quickly to actually see them face to face if they want it. And this mixed message made things very, very hard for the staff as well. So telehealth took a bit of a hit at that point. And then video consultations, where are they now? So in the UK, less than 1%. Less than 1% of consultations are done by video. Why that? Well, it's not evenly 1% across everywhere. There are certainly some providers where video consultations are very well liked and in certain areas. But I think it comes down to the fact that for much of what you need to do remotely, telephone is just as good. And people have got telephones, and people are quite comfortable with telephones. And for the COVID care assistant, for us, the patient's need changed. At the start, they didn't know what to do, but very quickly they understood what to do. And I realized that what we were building was solving not the patient's problem, or even the doctor's problem, but the healthcare system and the government's problem. And that is a problem. So where did it succeed, though? It's not a total disaster. It's actually succeeded quite well. Actually, in general practice, total triage has continued and is actually quite popular. At least with the practices, because it helps them manage demand. And there's been the rise of virtual wards and remote monitoring. So in the UK, two companies, Doctor and Dockler, are actually servicing a lot of the needs in the NHS as they do virtual wards. And video consultations continue in some settings. So out of hours, where I did a lot of work, it can be very, very helpful, particularly when you see a child who's being reported to be unwell. Very quickly being able to eyeball them actually makes a big difference. Or supporting nursing homes or care homes. Or certifying death, oddly enough, is actually, because of the legal restrictions, it can actually be a very, very useful way of doing this. And in some outpatient situations, in hospitals, it works very well. So I spoke to Peter Thomas, who led the implementation of telehealth in the emergency department at Moorfields Eye Hospital in London. And they implemented video consultations for their emergency department. And they found it tremendously successful. And they still found it successful. So 300 patients per day using it during COVID. It's down to about 100 patients a day just now. But they still say that 50% of the people that use it don't need to be seen in the department at all. 25% can be referred straight onto a specialist clinic, and then the remaining 25% can be brought up to a department that is empty and ready to see them. So telehealth definitely does work, but it is a mixed story, and the lesson here, more than anything, is it's about fitting it to the right place. So how about the report card then? So you didn't do so well with artificial intelligence, but I think for telehealth, I'll give you a better score. We'll give you a B+. It's not perfect, there's some problems, but it did actually help at the time, and it is actually helping right now. So I think that's not too bad. Sniff, sorry. So next up, contact tracing. Now, contact tracing, I'm going to be speaking to some epidemiologists, some public health doctors here, and I apologize, but for those that don't know, contact tracing, the basics, is simply speaking a technique for interrupting the transmission of communicable diseases. Now, I thought this is something that was centuries old, but accordingly to the research that I've done, it dates back to 1938, at least formally back in New York when they were using it specifically for interrupting the transmission of syphilis, communicable disease. That's a great idea. So how does it work? So the basics of contact tracing, for those that don't know, is you need to identify people that either have an illness or are at risk of having this illness. And then they need to list who they've been in contact with. Who have they potentially communicated this with? Like, which people, where have they been? You then need to speak to those people that they've been in touch with and just check that they're okay. They need any treatment. Have they been in touch with anyone else? And then you need to guide everyone as to what they need to do. And then you need to follow them up afterwards. So that's actually a fairly straightforward thing, and it's combined with testing, it's combined with quarantining, it's combined with distancing and masking and other measures, and that's been the stable of public health interrupting communicable illnesses for decades now. But it's not without its limitations. It's because it's manual, so it's difficult to do. It's quite resource intensive, and it relies on human recall. When you phone someone and say, well, let's think about this. If you think about COVID, like, who have you been near in the last 5 days? I mean, we're all in here. You know, could you recall everyone that was in here and when you were in touch with them? That's going to be difficult. Well, transmission of sexually transmitted infections is maybe slightly easier because it probably sticks in your memory a little bit who you've been near, but not with respiratory illnesses. And it can be stigmatizing as well. So again, I gave you the example of syphilis here as well. You know, it can be very, very difficult to engage with people, particularly if they're identifiable, that you might put someone else at risk. So contact tracing is not without its issues. So digital contact tracing, well, maybe that can address some of the issues. And again, doesn't it seem very well suited to the pandemic? It's scalable. If you can do this digitally, you can do it for many people very, very quickly. It can be very, very fast at responding to the problem, and it can be very, very good at determining the contact details. You might not remember where you've been, but your phone remembers exactly where you've been, particularly if you've left the location on. It can be made anonymous, which can remove some of the concerns about privacy, and it can be used in addition to the manual methods as well. And done well, it can integrate with the other systems to collect epidemiological data. So once again, what's not to love? Digital contact tracing. This is a great idea, isn't it? But there are some problems, and there's always some problems. In this rush to solutions, people often overlook the problems and kind of push them aside. Now, in the pandemic, we did have other things to worry about, of course, but there is digital division. Not everyone has access to the internet. Not everyone has access to these devices. Not everyone has access to the funds to pay for these data. And that can lead to certain groups being underserved. The technology may not be accessible for different groups as well. And as a result, those people who are most at risk of the negative consequences of COVID are doubly underserved in this situation. And then there's the consequences of false positives and false negatives. During the pandemic, if I got pinged and had to stay at home, I could work remotely. I was working remotely anyway. But for a lot of people in lower socioeconomic groups, they had no option to stay at home if they were pinged. That was it. They either had to go to work or they stayed at home. And if you don't have adequate government support for people, why on earth are they going to participate? And then there was concerns about surveillance, security, privacy. When trust evaporates in your government or the state, it becomes very difficult to convince people to use these technologies. For the UK, we had the NHS COVID app. And the COVID app was trialed in one form in the Isle of Wight, which is an island off the south coast of England, around about summer 2020, and didn't do quite as well. They were using a centralized database and record. It didn't seem to have as much impact on the patients or the people that were exposed, and it also used technology that was superseded by Google and Apple's joint efforts to use Bluetooth. So it was relaunched in September, and actually, the UK COVID app, by all measures, seemed to be at least a partial success or a success. It was used not only for contact tracing, but it was also used for symptom checking, for carrying of certificates, for local info, and access to payments as well. So if you had to isolate, it was a way of getting it done. Now, it was downloaded 29 million times, and I know in France, actually, your app was downloaded 50 million times, I think, as well. So it's a pretty reasonable number of that. Zoe app was another app where people used this. They did active symptom checking, and that was quite successful. So 4 million people at one point regularly used this. And the Zoe app is at least claiming that they were involved in the identification of loss of smell and loss of taste as a cardinal feature of COVID infection. So these can be very, very powerful tools. And before the pandemic, there was a lot of thinking that it would have to be about 60% adoption. The UK hit 29% adoption along the way. It went up to 38% when people needed to use it to check into venues like pubs, but it went up. And then the question is, did it succeed? Well, actually, in the UK, it seemed to perform quite well, or at least according to this study. This is from Nature in February 2023. And in this study, when they looked at an epidemiological impact of the COVID app, there was a number of sort of conclusions. The first of which is that they felt that digital contact tracing played an important role in reducing the transmission of SARS-CoV in England and Wales in real-world practice. And they consider it a valuable health measure for reducing transmission in any future epidemic waves. Note that we're not using it anymore. And they felt that it had prevented 1 million cases of COVID, 44,000 admissions to hospital, and 9,600 deaths, and they figured that that was an underestimate of how much they did. So they're certainly coming out on this quite bullish. But then, well, how was it elsewhere? And this is actually a remarkably difficult one to answer as well, and I've had a little look around this. There were some early successes. The early successes of using contact tracing seemed to work mostly in countries which had had previous experience of diseases like SARS, and also where the use was mandated and they had centralized records. So we're talking about places like South Korea, Singapore, Taiwan, and so on. Looking at France, and I had a little look at this as well, my understanding is that the French app was downloaded, 50 million times? So that seems pretty good. But then a survey said only 23.5% of people who downloaded it actually enabled the contact tracing at all. And why did they not do that? They said they didn't trust that their data was going to be used. They said that it chewed up their phone battery too fast. They were worried about the privacy as well. So there's a kind of mixed bag around the world. Certainly I'm being told, and reading in the UK they're quite happy about this, but then elsewhere it seems not. So I think in this review from Digital Health in May 2023, they said that digital surveillance had, at best, a negligible impact on mitigating the COVID-19 pandemic. But if you mix it with other features, it may actually make a difference. So what next for digital contact tracing? Well, the recommendations are simple. You need to establish the effectiveness. It's not just about downloads and interaction with the app. You need to make sure that people actually follow the instructions and that it makes a difference. And then the second recommendation, and this is from the Ada Lovelace Institute, who looked at this in April 2022. And their discussion was about making sure that you effectively communicate to gain the people's trust. In short, the government needs to be trusted when they say use this app. And there was a great absence of this. Not only that, but there was an absence of understanding in leadership as to what the technology actually even did. So how are you going to convince people of this? Now, in the UK today, I've been attending this course, but Matt Hancock, our health minister, has been giving evidence at the inquiry. From what I can see, he's been coming in for a bit of a criticism. So let's see what he has to say about the COVID app in there. And then the third one is that the interventions that you design to support people if they're asked to stay at home have been designed with it in mind. If you're going to require people to stay at home to protect the rest of the population, you really have to support them to actually get some money through the door. And this wasn't happening for some groups as well. So speaking personally, my wife at that time was a self-employed individual as well. There was no support. Well, I think there was a tiny bit of support, but if you were a self-employed person, there was nothing. What are you supposed to do if you say, well, you have to stay at home now, and there's no support? Things have to be designed together. So in terms of the report card, I've scored contact tracing. I'm sorry you get a C, and it's part because I can't quite work out whether you did make a difference or not. I'm being told that you made a difference, but some people said you didn't make a difference. Some people are quite unhappy about it. I think there's work to be done. So there's our report card. The question is, in summary, so we're looking back on e-health, digital health. What did it do right and what did it do wrong? Okay, so what did we get wrong? Well, I think it's fair to say we were underprepared and undertrained for all levels. There were problems with the data, as I've talked about, and its fragmentation, but there's also problems with the products and the services that we designed. In short, I believe that we focused on the wrong people. We focused almost exclusively on the healthcare system and the government's needs, and then sometimes some of the people that worked in the healthcare system. But I don't believe that we focused on the needs of the patients and the needs of the people anywhere near enough to actually make a success of this. And we'd fallen in love with the solutions already. techno-solutionism is the phrase that I've heard. We were uncritical in how these were adopted. Now, in some ways, we had to adopt things quite fast. But we also adopted a lot of solutions without thinking about what the consequences for the patients and the healthcare workers was. And this is something that we're seeing more of, is as more solutions get added on, it's actually increasing the stress of the staff because they're not integrated. And we were rightly called out on the hype. And I think we need to learn from that. But I'm not going to ignore the fact that we did have some things right. We had set up some of the foundations in there. There were some successes with these technologies and other technologies as well. And we have established that in the right circumstances, digital contact tracing, telehealth, total triage, and artificial intelligence could help in a healthcare setting if we correct some of these issues. And we found better ways of care, virtual and remote care. And then where end users were involved in the design of products, we've actually seen quite a lot of success. So in the UK, there's a company called Accurix that works very, very closely with the end users on their product to help doctors communicate with patients and have rightly succeeded in their work there. And I think in this way, we can learn some lessons for the next time. So where are we now? So pandemic, COVID is kind of pushing back a little bit. But I'll argue we're in a really difficult situation right now as well. Our staff are burnt out, and I talk as a person, I had to take 5 months off with burnout pre-pandemic, but I had to take some time out. So I've seen this, I know how it feels, and right now it makes me very, very unhappy to hear that in the UK, 39% of junior staff are reporting high or very high levels of burnout right now. That was actually June 22, it's probably higher now. And even more tragically, in the US, one doctor takes their life every week. One doctor takes their life by suicide every week as a result of mental ill health and burnout. And staff are sick. They're not only sick because of the stress, but long COVID has taken out, by estimates, about 10,000 staff. And there's 2 million people in the UK affected, 10,000 NHS staff affected by this as well. And then there's people striking as well. In the UK, junior doctors striking because they've seen their pay reduced by 26% in real terms since 2008. Demand is greater. I've already talked about the chronic conditions. I've already talked about this backlog. Supply's even lower. And then, if that wasn't tough enough, we've also got the economic constraints as well. We don't have the money to do things the way that we did them before, even though the way we did them before arguably wasn't working. So what do we do? So this is my thoughts here as I wrap up. We need to fix the data, and we need to fix the plumbing and the interconnection. Almost everything we do in the world of e-health is data dependent, and we've made some good steps, but we really need to assemble comprehensive data sets. We need to take some time to make sure that the data serves all of the populations that we serve, and not those privileged few that have the right to care. We need to make sure that it's diverse and inclusive and accessible to those that need it. And we need to work more on international rules for data sharing as well, in part to correct for these gaps in our knowledge. We also need to give power back to the people, and specifically, we need to give our patients full access to their data. And I say this because we're awful at doing it. I mean, we are admittedly, as a system, very bad at doing this. And we will occasionally let patients have access when we're forced to, in the way that we like, when we deem it to be correct and they will not misuse it in some way. This is not good enough. And why on earth would the public trust us with data if we won't even trust them with their own data? And we need to fix this. So we have an opportunity to do that. That will improve trust, that will improve access to data, and it will improve everyone's ability to self-care. We need to train the staff. We need to make sure that the staff are ready for when this happens again, that they can help develop and implement and monitor the technology. And we need to make sure that happens not only with the people that are using the technology or embedding it, but those people that are creating it, putting it in place, and then even up to the very highest level. They need to understand what this technology is. That's been a theme that I've been hearing today, is that there's a lack of understanding at all levels as to what this can do. And then speaking personally, I represent what I believe to be a kind of new group of healthcare professionals or doctors. We're doctors as builders. Because I see my role as a doctor now more about practicing my medicine through the products that I build and not the patients that I see. This is a growing group of healthcare professionals that will allow us to make up that huge gap and treat people at scale. And then we also need to protect the staff. We can't overload them with a lot of systems. We need to make clear how to use the tech so it doesn't interrupt how they're working. And if we are successful and we free up time for them to care with people and really interact, we have to be careful that we don't just pour more patients into it. And this has happened time and time again. So if technology helps and we get time back, let's work hard to try and preserve it. But ultimately, we really need to resist over-promising. We need to focus on the problem. We do not need to just love the solution and try and make it fit, because that way lies madness. And remember, if we come back to the oasis and the desert, when you're in the desert, your problem is not that you can't find an oasis. That is not your problem. Your problem is that you need water, and you need food, and you need shelter. Just so happens that an oasis has that. There are other ways to provide food, water, and shelter in a desert too. We have to focus on the problem and be mindful that there are different ways to solve this. And if we do this, and if we learn from what we've done before, then I think we may have some success. So anyway, thank you very much.